for the Veterinary Dental Forum, American Association of Equine Practitioners, and University of Minnesota. He teaches equine dentistry to veterinary students at Cornell University, and recently he accepted an appointment for clinical services at Cornell University for large animal dentistry at the Equine Farm Animal Hospital. In addition, he is also a partner at the Laurel Highland Veterinary Clinic in Williamsport, Pennsylvania, which he actually drove up from Pennsylvania this morning for us, where he does comprehensive dentistry for both small animals and equines. He's currently finishing a residency program in small animal dentistry at Cornell University. And Dr. Earley is also on the specialty organizing committee for developing an AVMA approved equine dental specialty, and the AVMA is our American Veterinary Medical Association. In addition, he's a fellow of the Academy of Veterinary Dentistry for Equines, and at home, he runs Laurel Highland Farm with his wife, Mary Jean, and their two daughters, Lauren and Janelle. The farm also raises fell ponies, Angus beef cows, hay, corn, and soybeans. And in his spare time, he enjoys trail running along with cross-country and downhill skiing with his family. So please welcome Dr. Edward Earley.
Good morning. I thought about this talk a little bit. Is that too loud? Okay. And so what I decided to do was to condense the talk into some of the things that I see commonly in dentistry and focus this talk on those things. And then at the end I was going to give a case example of computed tomography, CT, and how that really helped on a case at Cornell. So you can kind of see some of the things that are done at Cornell and why you would want this additional imaging. So today I was going to talk about canine reduction, GVEC, incisor leveling, and then a disease or a syndrome that is becoming very prevalent. It's basically tooth resorption. You've probably heard of it, EO, TRH, and then the case. So the first thing I'm going to talk about is reducing canines, and it is a procedure. First of all, in dentistry, it seems like a lot of these procedures that we have done, it has been done because it's always been that way, and there's really no evidence of why we would do these things. And in the past, we have thought that these teeth may get in the way of people trying to get a bit into the mouth, which has kind of set the precedent for some of these procedures. And so, we have in the past been wanting to reduce these canines. And the problem with the teeth in general is we forget that they are a living structure, that they have a blood supply up through the center that is producing, that reacts with a cellular layer and it produces dentin, which helps this tooth to continually erupt. And that's particularly important in equine dentistry because their teeth are designed to continually remodel and erupt. And so if we expose that tooth in that vascular cellular area in the center of the tooth, we can set off damage. And as I was going through my studies for the equine and the small animal residencies, they had us read a lot of human literature. And they talk about Halt Disease or causing an infection in a tooth in humans that can go on sometimes 20 to 30 years before you actually see the effect or the damage from the procedure. So basically, losing track of time. One thing I was happy is I'm a little younger than, and I can't say I'm 3 decades yet. I'm 1 year shy of 3 decades. But this is a case that years ago, probably about, well, I got it right here, in '97, I had been to a conference and we were being taught how to reduce and cut canines. And then 11 years later, I came back and was watching this horse, and by that point I realized that we were damaging teeth. But the owners, my clients at home in Pennsylvania, they're not going anywhere. It isn't racetrack, or anything like that. They're pets, and they're there for life. And with a horse averaging, early 30s, if I do something that's bad, I'm going to see it. So this was one of my flag cases, probably 2004, 2006, that I put up at AAP, that, we need, this horse was done by me, I did damage to the horse. And that's one thing I've learned in life, just to be honest. And I wanted to bring it out to practitioners that this is a reason why we need to be cautious about some of these procedures. And this was one of the first flag cases that I presented to say, hey, I did this, and we need to watch and we need to question the procedure. But you can see on this how the tooth is slowly dying, the gingiva is trying to grow over top of it, very painful. And what I got from the owner was that the horse just had a difference in personality. Normally he's a happy-go-lucky horse that I can ride. Now he turns his butt to me in the stall. He doesn't want anything to do with me. Well, the horse was in pain, and that's how the horse was showing his pain. So working through this is what I was wondering with the x-rays, but basically, and I'll move through these cases, but this tooth is just decaying and resorbing, and literally just dying, and it's all infected and very painful. This tooth is buried into the bone, and so basically what we have to do when we have a canine like that is we have to open up the gingival attachments, we have to burr out the bone and try to expose and get down to that root. And this is the dying tooth. There's the gingiva that was capped over top of it. So this was basically blowing the whistle on myself and trying to bring this out to the profession, that we need to question about when we start doing these canine reductions, and that it is going to be something that maybe 10 years or more later before we actually see the damage, but be careful with some of these procedures. Just showing how we cleaned it, threaded it, flapped it, and closed it. And then on the post-op x-ray, just showing that tooth was completely extracted. Coincidentally, this tooth was doing the same thing. About a year later, I went and had to take that one out too. Periodically, I'm going to show you some slides of some kitty work that I've done in the past. This is Haley. She's a three-legged tiger. I was doing some work through my residency down in Arkansas at a refuge, Turpentine Creek, and it was a great experience. Now this is another case. Regal came in and was presented same type of thing. The owner said that he's just not, this horse isn't happy. He says, normally I give him an apple, he doesn't want to eat, he just spits the apple out. If I put it in pieces, he'll throw it back in his mouth. And basically, you can see this canine, it wasn't reduced as much as the previous case, but it still had set off a process. In addition, we had calculus forming here, and you can see these two little spots, little drainage tracts. And notice how long that probe is right there. That's the same probe buried into the mandible. So going on, these are x-rays, and of this horse, this is the maxillary incisors. You can see these little lytic lesions here. We're going to talk about that later. But in this particular case, pay attention to this area right here. And we obliqued it a little bit, and you see that shadow right there. And what we're trying to show you is that this is from the back of the tooth. We had another hole right into the tooth and penetrating down in. We opened that up with a flap, and this is all just a caseous pus material. The tooth just fractured right off, and we took that piece of tooth out, and then there's a remaining piece of tooth that we had to surgically cut out, and this is the hole where all that infection was. Here you see we're burying it out, trying to isolate that tooth, and there we got everything cleaned out and flushed. And once again, trying to get fresh margins and to close it. And our post-op x-ray, you can see we've gotten the tooth, and you can see this big area right here where that huge undermining abscess was right in the mandible. Just showing at a different angle here. So those are two cases of canines that, so when we're having work done on canines, it's amazing over the years how I've gotten less aggressive. I can remember 6, 7 years ago, I said, well, maybe we should just lightly reduce those canines. I've come all the way back to the point that I don't touch them. They're a natural tooth. They're not doing any damage, and just try to not create more problems. How many here know what a bit seed is? Show of hands. Okay, so a bit seed is something that has come out recently, thinking that this is the first cheek tooth, and thinking that if we do a little bit of tapering on this tooth, when that bit sits in the mouth, it won't cause any irritation. Well, the truth of it is that they've done x-rays with the bit in the mouth. That bit actually sits up here, nowhere near this tooth. But mentality is if a little bit is good, a lot is better. And you can see how in this situation here, they've taken over half of the tooth at a steep angle and just ground it down. Pay attention here. See, these are the normal root structures. When a tooth has been damaged, it starts to lose its roots and we start to resorb. And see how we don't have any root tips on this tooth here? It's just from this tooth being chronically exposed and infected, and the tooth is slowly dying. And so that's what we're going to talk about here a little bit, is about some cases with bit seeds. This is a case that came in last fall. The owner had been to the Quarter Horse Congress and had bought this horse. JC's a 13-year-old quarter horse, and when they bought the horse, they called our clinic. He's got some teeth issues, but we're not sure exactly what they are. Should we get the horse anyways? Well, they got him. When they came home, and we see these extreme bit seeds, fractured teeth, and so this was Christmas time. We worked on this side, and then in January we worked on the other side. But just to show you from the bit seed here, it's chronically, once again, we have this chronic infection. We're losing our detail of the root. This tooth is kind of in the process of resorbing and disappearing like that other tooth had already done, and we've got a lot of reaction secondary to it. And the problem was, as we tried to orally extract this tooth, this part wasn't going to release. It was just kind of ankylosed in there, and we ended up fracturing the tooth as we tried to extract it orally here. And so once the tooth was fractured, we were left with no other option but to create a bacotomy and to go in and try to isolate and resect those roots and elevate them out. And this is showing the fragment that we fractured during the oral extraction, and this is what we had to take out surgically. And this is all that remodeled root on the distal aspect that normally is a nice, sharp, point like this in an apical area. It just was, from the chronic infection, was going in through a decay process. It just shows how we put a PVS, a polyvinyl siloxane plug in there from the oral side, and then we're packing it and pushing it into the right location from the bacotomy side. Horse healed up fine. This is just a closing up process, and after everything's closed. And then that was around Christmas time, and like I said, we went and got the other one out just in January. But I guess the point is that it could be a major surgery just from a bit seed where we have to go through the side of the face to get the tooth out in certain situations. That's Alex. Alex had some periodontal disease and a root canal. Petito, this is a case that kind of pulls these two concepts together. This lady was a real nice lady that was living most of her life in California, and she moved over into central Pennsylvania. And she had a big warm blood barn of about 25 horses with a big indoor arena and everything. And her husband got relocated to Pennsylvania, and she had to sell everything to move. And she decided she was going to keep one horse out of those 25. She was going to keep Petito, which is her favorite horse. And she was excellent about keeping records. She had dentistry performed on Petito whole life, about twice a year, and she had all the records there. And this is a case of over-aggressive dentistry, over-filing, and just seeing where we're at with him now. So if you look at these teeth on the oral exam, you can just see these teeth are decaying and have been overfiled. See this tooth? That's actually remnants of a tooth that has just been overfiled from bit seeds. The bit seeds, these two teeth are the ones that they tend to want to file to create this bit seed. And it's hard to get out of this mindset. And you can see on this side, it's not quite as bad on the oral exam for this 6, but this upper one has been filed almost right to the gingiva. And if you go further, this is a canine that has been filed so much that it's just chronic, it's a pulp that is filled into the pulp form that it's just, if you touch it, it bleeds. It's just chronically infected and painful. And, once again, just filed right down to the gingiva with these big holes in the center of the teeth. These teeth are painful. This is a dental record. I was amazed she had all these records. But this was from 1997. We cut the incisors, reduced the overbite, reduced the canine. So literally they just cut right through the incisors, filed these canines, and you're seeing what I saw in the exam as a result. So that was in 97. 99, they came back and they filed more. They did more bit seats. They recut the incisors. And just continually over-aggressive dentistry on these teeth. And in 2000, they did minor reductions on the incisors, and they had some calculus on the canines, still reducing these teeth. This is the classic. In 2009, I don't even know how they could draw this because you saw how much they had been filed down. Maybe sore for a day or two after we work on it. 106 and 206, which are these two teeth that I showed you on the picture, how they've been filed right to the gingiva. Look at this down here, bit seats times 4. So 206 and 106 are expired or dead, but went ahead and did bit seats on them again. If it doesn't work the first time, do it 2 or 3 more times. These are x-rays of Gatito, and he also has resorptive lesions going on, probably from the aggressive dentistry, which we're going to talk about the resorption here in a little bit. But, same type of thing here. These canines are resorbing. So we had to stage Gatito because many of his teeth were just very decayed, resorbing. This is that 106 that's been filed down to the gingiva. You can't even hardly make out structure here. You can just see that, you pay attention here, there's a little bit of area here that is kind of marked. You'll see this ends up being granulation tissue and infection that we got out. But even these roots here aren't normal. The whole mouth has just been over-filed over the period of his life. Going to the other side, you see that tooth is just fragments. And so we had to kind of make a treatment plan. And even on that one tooth I showed you that looked normal, you can see how there's a hole in the center and a perforation. There's actually a little, starting to get a little fracture line on that tooth. So, I mean, even with the x-rays, and this is the one that was just down in pieces. It's just in pieces, just sitting there. So we make a long story short, we had to cut all these teeth out, and you see how we're isolating the canine in there. That's the one that was just oozing. It had the 2 little spots of bleeding coming right out of the tooth. And, we had to reduce the bone around it and elevate the tooth out. We're gradually pulling it out, and we're making some smooth margins, shredding it and trying to close that flap. As we're getting ready to close it, and just showing how we've tried to make a full flap procedure, like we would in other species, showing how that tooth has been completely extracted. This is that tooth that looked normal on the oral exam, but had that furcation or that spot right in the center. So we're sectioning it through the center of the tooth, and then we're going to extract out. There you see how we split the tooth in 2, and then we took it out in 2 pieces. And post-optics, making sure that we got the entire tooth. Now we're watching these teeth, and we're trying to stage things. Just going through as we extracted, we did multiple extractions, and this is that granulation tissue that I was showing, just active inflammation above that tooth that I told you on that one x-ray that we could see trying to keep some kind of packing in there over that tooth. This is that track where that granulation tissue was. But this is a day's work of taking all these remnants of teeth out from over-aggressive dentistry. And Tito was better, but he still has his incisors that are very painful. And the owner reported that he was 50% improved, but now we're trying to stage things and we're getting ready to take the incisors out later this year, depending on how he does. Pain in general in horses, especially with dental pain, is hard to evaluate. And I was talking to a person here that was saying her horse just wasn't right. And really, you as an owner are going to be the best person to evaluate pain in a horse. It's subtle, but if they aren't right, usually they're enduring a lot of pain. If you or I had this kind of disease in our mouth, we would be miserable. And if you read through the human textbooks on dentistry, most of the time, especially like in the endodontic textbooks for root canals and that, the first 3 or 4 chapters are nothing but pain and how they deal with it. And pain is the #1 reason why people go have their teeth worked on. Yet in horses, we don't recognize it. And it's just, their teeth will go to a very severe stage, and they will still try to eat just by the nature of the animal. But they're still very painful, even if it's hard to pick up. We had a horse come into Cornell a few weeks ago, and it had raging sinusitis on the right side of its face. And there was a bad tooth on that side of the head that had caused a sinus infection. And I was doing my oral exam, and I was on the left side of the face in the mandible and checking tooth by tooth. And I dropped my probe into a hole, just like on that one horse on the Canine that had the big pus area in it. And that horse was so painful that she dropped down and sat like a dog. I mean, I hit the spot. So here I'm at a dilemma. The most painful spot is this tooth over here that nobody even knew about. But I can't, if I just address that side of the mouth and send the horse home with a draining sinus infection, so we got the whole thing done in, did I do that? Oh, I thought I might have pushed the wrong button. We ended up, I got everything done, but I told the owner, I said, I'm not sure we're going to be able to get all this done in one procedure, but we got the sinus infection and that tooth taken care of, and we went over and took the real bad tooth out on the other side. So it's just a point about pain in horses and dentistry is it's very hard to evaluate. And as we get into the tooth resorption, I think that's the most thing that's striking. I'll get into that a little bit more, but one of the more striking conversations I have with clients is, when do I make the decision to take all these incisors out because of this resorptive process? And it's hard, and then most of the time, by the time we've made that decision, they come back even in the next week and they say, oh, it's amazing, I got my horse back, it's happy now. Sometimes when you live with it or you aren't quite sure of your evaluation, you aren't sure if they're in pain or not. So it just brings it down to the question, these are healthy, happy teeth, and that's what I like. I mean, I don't want to destroy the teeth. Cat Casey, that was just 2 root canals. Casey. And now we're going to talk about incisor leveling. It's the same type of concept as far as, you see these teeth and they're crooked, and your first knee-jerk instinct is, let's get these things level. That's not normal. But the truth of the story is, it's normal for that horse. And trying to explain that is, if you look at this head carefully, it is, the eyes, like this eye is kind of leaning forward, this one's kind of tipped back, and the whole head, the maxilla is kind of curving around. So we did some x-rays. This is one of our first cases. This is the oral exam on that case. And if you look closely, this arcade is kind of rolled out, and this arcade has a steeper angle to it and is rolled in. And as we're looking at the hard palate structures and the angle of the teeth, this has started catching my eye. This is just some anatomy that I'm not going to go through, but it's just showing some structures, the vomer of the maxilla and the nasal process and the maxillary incisors. This little groove tells us that it's maxillary. But basically, we've been looking at x-rays and trying to see the crooked bone structure. And this is just showing that the red is the upper maxilla and the green is the mandible. And if you go from the corresponding first cheek tooth to the outside incisor, you can see everything's kind of shifted to the right with the maxilla. And another way to put it is, that's the same horse side by side, but if you put it here, I outline the green is the mandible and the red is the maxilla. And you can see how everything is kind of shifted over to the right and actually rolled over. And then taking it the next step further, that vomer right down through the center, you can see the curl in the inner incisor canal. Everything's shifted over to the right. So this horse has a crooked head. And what's happening with these teeth? They're adjusting to a crooked head. And so that works in that horse. So why would we want to level the teeth or change the angles? We let the horse tell us what we need for angles of occlusion and not try to have this preconceived idea of everything should be level and the same angles. Let's try to do dentistry to each horse. And so this was kind of another case that was an eye-opener for me. I started x-raying horses. This is the same horse, and this is the point I wanted to say here. Now this x-ray plate has been put into the mouth, and we shot down through the head, so we only saw the maxilla. But pay attention to these teeth right here. These teeth are straight up and down, looking at us. These teeth are tipped off to the side. So that's the way the teeth are orientated in the skull. So why would we want to change that? The CT images just showing the difference. This is the hard palate. This is the cheek teeth. We have a little different curvature here. This is on a different horse, but I just want to show this horse is a classic. You can see here, you got a short hard palate on the right side, and the teeth are kind of rolled in. And here, the hard palate kind of goes out a little longer, and the teeth are actually kicked out. So these are all these different asymmetries that we're just starting to look at and realize that we don't have preconceived concession. Everything's different, and it's so in humans. We play with palatal expanders and braces, trying to tip and move the teeth, but it's more. It's about function, and we have. This is a dog I worked on yesterday. You can see normally these teeth are underneath and behind the incisors. You can see how the canines shifted forward. I'm not going to change that. The owners came in yesterday wanting me to reduce these incisors or remove them. We removed this incisor here so that canine would work. But if I remove those incisors, same concept as filing incisors in a horse, this whole mouth would have dropped, and I would have had even more pressure on the tongue. And we already have some sores of the mouth closing a little different than it was. And functionally, this is a 7-8-month-old lab puppy. Functionally, it's working great. So even though it's not what we like to look at for a normal bite, it's functionally working in this puppy. So we're not going to change it. And so that's how we need to look at it with horses, as far as showing the different three-dimensional evaluation of how skulls can twist and turn and be abnormal. And so I'm just going to run through this quick. We looked at 42 cases. Bottom line on this is that we looked at all these different changes. And this is already shown with these differences here. But we could see changes both radiographically and on the oral exam between 94 and 98% of the time. If there was a diagonal or the incisors were diagonal and not level, we could trace it back to skull asymmetry. So the point is that those incisors being not level is more of an effect than a cause. And it's the effect of a skull that's crooked. So we don't need to change it. This shows the numbers in the conclusions. This guy was 700 pounds. I mean, his paw was bigger than my head. I'll show you a picture of him here a little bit later, too, what we were doing with him. All right, so this is a project that we're trying to publish right now. There's a big group of us that have been working on this. The pathology papers being finalized this week, and we're supposed to be finalizing the first of 2 papers here as we get into February. The results are done, but this is the disease, the equine odontoclastic tooth resorption and hypercementosis. In short, tooth resorption. And tooth resorption is seen in a lot of animals. This has been a big project across the United States. We have multiple authors on it and multiple veterinarians contributing cases to it. But in general, when we see this tooth resorption, in other animals, tooth resorption kind of has that lytic effect and where the teeth kind of literally dissolve or resorb. But the horses are a little bit different. They lay down cementum to try to patch the inflammation. So that's where we get this H for hypercementosis. But in the hypercementosis, you see this bulging juga here. That's the hypercementosis, literally eroding the bone away and trying to build up around the tooth. This was first reported in 2004. And then again in 2006, it was again reported. So this is something that's newly recognized in the last 10 years. But what's interesting about it is since 2006, 7, 8, it was just a gradient scale. We are seeing more and more of it. And so that's what prompted us to do this study. But basically, the resorption is seen in all species. But it's just how the horse has the resorptive lesions, but they also have this hypercementosis. And you have 3 layers in the tooth, the enamel, dentin, and the pulp, which is the center of the tooth. And these lesions will destroy and go through all layers. And then the only other point, which we talked about a little bit already, is this condition is very painful. Even though it's hard to recognize in the horse, it's a very painful condition to the horse. This is just about the design and all the things that we did about it. I'm not going to spend too much time here, so we can kind of move on. This is the distribution. Ages were from 10 to 34. Most of our horses are 22 years old of age. It was the average, median, and most of them were gelded. We had two mares in the study. And there's a reason for that. But we had from multiple states showing, but it's reported in all states now. So I'm going to spend a little bit just on the imaging so you can see what's happening here. This is some CTs, and this was contributed by Dr. Cox, University of Minnesota, and one of the referring veterinarians out there. They sent these images to us, and they're going to be part of the paper. But these are CT slices. You can see how there's just this lytic center right inside the tooth. And CT is nice because when you take an X-ray, you're looking at the whole tooth. You got to take a summation of that whole tooth, so you don't know what it looks like exactly in the center. You got some areas that are shaded, but where's that at? You got the cementosis. But as we start looking at CTs, even these cases that have the hypercementosis, they still have this lytic area in the center, through the whole tooth. Here you see a little spot, and then just the neighboring tooth, you can see it's just totally destroyed. And usually the outside incisors tend to be affected first, and it progresses towards the center. And then usually the center incisors tend to shorten, and I'll show you some images of that in the X-rays. But this is just showing, this is the group that I was originally on Parkinson's for the time being. On radiology, this is the youngest horse in the study, and Dr. Galloway was very sharp on this case. Everybody, I think now that we're looking for it, we're realizing that it occurs in younger animals. It's just that it's hard to pick up. And things were kind of inflamed on the gingiva here, but here we had this little patch of gingiva. Remember that canine? Whenever a tooth is has some exposure to it, the gingiva tries to grow over top of it. Well, he picked that up. He's showing just a little bit of cemental reaction on this side and then over here, just a little bit of area of reaction. Here he showed it as he filtered it out. But it's very subtle, fine. But he ended up taking those teeth out and sent them into Michigan State, was doing our pathology for this study, and he sent it to Dr. Smedley, and it had early lesions of tooth resorption. So I think, it's a gradual process, but it takes us sometimes a while to recognize it. He happened to catch that. So that was the youngest horse in our case. here, here's these lytic lesions on X-ray, just showing how the tooth is kind of decayed right through the center of the tooth. Blackjack was one of the older horses in the case. Here, Blackjack has the hypercementosis, and this is what I meant about the blunting, where the root tips just kind of resorb. There's another case that from Wisconsin, and huge areas of cement that has just eroded through the normal bone, and you see it's bulging right out through the side of the mouth here. A lot of times, as you look at these cases, you almost think that it has another tooth or something coming out of the side of the face, and it's just these huge bulges of hypercementum. There's here, lytic lesions here. So, move through these. This one here had a deep bone infection associated with the resorption that was going on. That was also in there. So this Tyler, this is one of our cases. This is one in 2007, just to show you how this disease can progress. This is 2007. We picked up some irregularities, had some cemental reaction here, had a little bulging going on there. And then 4 years later, the same horse, see how that bulging got worse? It was amazing. That was one case that progressed very rapidly over a 4-year period. And you see here, 2007 is 2011. So some of these cases are very rapid in progression. And so when we get these cases, this is the kind of thing that if you have a horse with this, I want to look at x-rays, I want to try to evaluate the pain, the weight condition, just overall health of the horse. And if it's a question about whether or not it's time to take these teeth out, we'll kind of watch if it's something like this. But as we get to this stage, it's very painful at this stage and time to consider taking the teeth out. Just to show, this is from Dr. Brile in Texas, and she had a case that actually shows it in the premolars. And so, I mean, it's not just incisors and canines, it can occur in premolars also. Haley again, that's the three-legged tiger. Okay, just a few quick slides on another case that just had a small lesion in the tooth. And what was interesting about this is on the gross you could see how it had infiltrated. Here's the x-ray, and if you go back to this case, this tooth over here looks pretty normal. So if we would leak that x-ray, so there's the tooth that you can see the lesion in, and you can see a small lesion that just hasn't, the tooth hasn't erupted out. See it, we see a small lytic lesion in the opposite. But these corner incisors are usually where we first see it. But we took that tooth out and sectioned it, and this is one that went into the study. And what was interesting here is you can see, this is your pulp, this is your dentin, this is your enamel, and cementum. And you can see that erosion going right through all the structures, right into the pulp. Just eating away at the tooth. Now this is that case, once again, from Dr. Cox. He did the CTs, and then he's a great anatomist, and he preserved the skull for us, actually, when we're done with this study and got the paper written. We're going to give it back to the University of Minnesota. But if you take these teeth out, these are the mandibular teeth. This is what I wanted to show right here, that bulging. That's where it usually first starts. And on those x-rays, you can see that little bit of bulge in there too. So, I mean, this shows it and demonstrates it, that that's where we usually first start to see signs for incisors. And there you can just see the lytic holes and the decay associated with that. We just split that same tooth on the back side so you can look at it. This case here, you can see it went into the study, but you can see the bulging and how it's remodeled the gingiva and all the bone is gone. It's just very invasive. And just shows the lytic lesions here. And then this is a cross-section. Once again, I mean, you just see how it's expanding and bulging and causing a lot of bone decay and loss. And that's why this condition is so painful. So, basis of this is we got a grant to do this study, and it seems like we got more information than we bargained for, and we still don't have a cause. But what I'm finding out is that there's probably multiple causes to this. And this is how I feel. I feel like I've been studying the tail, and there's a whole big another thing on the other end I don't even know about yet. this is a little break, and then we'll go into the session on Cornell, and I think I'll be done. But this is Zeus, and you see that canine right there? That's why I'm there with the group of people. We're going to do a root canal on Zeus. These tigers are meant to kill, and he was playing with a big blue plastic ball, and he got that canine stuck in the ball, and they were trying. Nobody wants to run into a 700-pound tiger and take the ball out of his mouth. So by the time they could figure it out, he's shaking his head and the tooth snapped right in half. And when we did the root canal, we still got pieces of blue plastic out of the center of the tooth as we were cleaning out the tooth. So here we're getting ready to do anesthesia on him, and we have to put a trach tube in. And if you look at this is a guy from Colorado, a veterinarian, and he's doing the anesthesia for us. And he had been doing those 200-pound cougars and cheetahs. And we got the Zeus, he's 700 pounds, and that pharynx is way back. And he's like, how am I going to get back there? So this is how you intubate, at least how he intubated the tiger. We reach down in. We're just using ketamine, which is, we're not using any gas anesthesia. He's got his canines right there. That's how far he had to get back to get the trach tube in. So I wouldn't recommend this, but we got the job done. So this is the final thing I'm going to talk about. It's sugar, and it is probably one of our best cases that we did at Cornell a year and a half, 2 years ago now. The reason I remember the date because it was on my wife's birthday. And it seemed like 2 years in a row I was up at Cornell working on my wife's birthday, which is February 16th. And so it was February 16th, and I was up there working around, but she says, no, you're not going to miss my birthday 2 years in a row. I said, no, this is good. We're just going to go in, and I'm going to be home, leave by 4 or 5. I'll be home time for dinner. Well, it ended up being a big case, and I was getting ready to leave, and he said, Ed, you want to scrub in with this? And you'll see in the picture. So long story short, I didn't get home till 11 that night. It was 2 years in a row. The third year, I made sure I made my wife's birthday. So this case came in with had a history of being kicked, and it came in down to our clinic. And every time it would try to eat, this is kind of soft tissue, saliva would come out these holes out of the mouth. And it was very unstable in the mandibles. We took some x-rays and wanted to kind of get a picture of things, and it's hard here, but we had like a fracture line here that we could see. And then we did an intraoral, and I could see a fracture line kind of coming up here. And we don't always worry about fixing fractures on mandibles. They have another mandible that works, and a lot of times in these minor mandible fractures, they'll get along, and as long as there's no tooth pathology, they heal pretty well. But this kid, as you can see, was losing weight. It wasn't getting any better, so we had the horse go up, and we needed to do a better evaluation of that fracture. So kind of keep in your mind that little line that I showed you on the x-ray. And so we've got sugar in for a CT, and it's a pretty neat thing up at Cornell. They have this big table on wheels. They anesthetize the horse over here to the right, and then everybody kind of with a hoist would put the horse dead center onto the table. And this table was moved back around and wheeled in. This is the CT device here. And so this horse is under anesthesia the whole time. So the next picture shows where we're putting the anesthesia through the CT so that we can have constant anesthesia while the table is clicking, moving the horse forward into the unit. And then as soon as the CT is done, we go right into surgery. I had a question here, Teresa, I think it was, about her horse maybe needing a surgery, and she's like, how many horses, or what's the chances of you having to go under general anesthesia? Most of our dental surgeries are standing. This is a case here where this had to go under general anesthesia, as you'll see. But most of ours are done standing, but we do cases under general anesthesia. This is one case. So this case, as they're getting wheeled in, we're looking at the CT. So this is looking from the outside as we're working across section, and we can see that one fracture line. But what we didn't see on the x-ray as we slice through a little bit, now we're getting into the teeth and we're seeing some damage. 2 teeth are fractured. And it was hard to evaluate that. Same concept that I was saying before, you know, an x-ray is going to put all that data right onto the film where we're slicing through and being able to get different locations. So this was very helpful. And then the other thing that was helpful on this case, look at this, on the inside of the mandible, we had another fracture line running forward. I could see this on the x-ray. I didn't know exactly which teeth were involved on the x-ray, but then we saw this other fracture. So actually on the inside of the mandible, we had like a V fracture. And this is important information to take in if we're trying to make a proper diagnosis and treat. And there you can see that fracture line, how it took on a different meaning on the inside of the mandible. And I showed a few other pictures here, how it's kind of wrapping around the bottom of the mandible through like that, and then this one where the mandible is just kind of shattered. So those are just, so this is at the point I'm ready to go home. Okay, you guys got it. This is a big deal. So they got a surgery team to put a bone plate in, and then they need a dental team to take the fractured teeth out. So it was a long, it was like 6 at night at that time. So we were there a long time. But basically, just showing as they're starting to prepare for the bone plate. We have a surgeon team on this side where we're going to put the long plate, and then on this side is where we're going to take the fractured teeth out. When we had 2 fractured teeth there, we thought we better just take the major fractured tooth out, worried about stability of the mandible. We left one in and we're following it. But basically, so this is the dental team chasing that fractured tooth, and the surgery team's on the other side. Just showing you this is a team effect. I love working up there. It's amazing what you can accomplish in surgery with a team. And it is a great team up there. You guys are very fortunate to live so close to a place like this for dental surgery. But you know, they're preparing things here. We're getting things opened up. Just going to go through here. We actually have a high-speed surgical burr trying to cut that bone down to access that. Show you the plate here. They're getting ready, and they have the plate in place. They have a big C-arm X-ray because we're trying to make sure that these screws don't hit the teeth, and so everything's got to be angled just right. There we're getting down to the tooth, getting it sectioned out. There's the tooth fractures that was cut out. Cleaning that up. There's our plate. We're guiding our holes. We left that tooth in, and we're watching that tooth. Long story short, that actually kind of resorbed, but the rest of the tooth is doing fine so far. Things closed up. This is she's a senior now. She had a fractured leg at the same time. And she's on the high school rodeo team and actually does very well in the state competitions in Pennsylvania. And they had a great fall season, and so they're both back together. But because of the nature of this being a rodeo horse, we thought it would be better to take this plate out, so we went back in, and it just shows the healing there, but we went back in and took that plate out. Sometimes taking these plates out is a little more challenging than putting it in, because we've got to find all those screws that was put in there and try to get everything undone. So it's just showing taking that plate back out and getting everything cleaned up. And so that was summer, and like I said, late this fall, this horse is competing and doing very well. Everybody's happy. Any questions?